It's oral. It's a pill. I would say it is, it's not a first line. It would be one that you might use if people refused other agents. Or, I've created a table for you in terms of flow of therapy in allergic rhinitis. If someone is on, has asthma and is adding it may help. So it would be something you added to. Usually. By itself, it is not powerful enough to control symptoms, but it may help in some patients. The big adverse effect to remember with this one is it has neuropsychiatric problems. So people may have abnormal or excessive dreaming. They may have an increase in depression. Mood may change. Suicidal ideation goes up, and reports of suicide secondary to singular have been reported. And those are rare, but it is something to pay attention to. It is fairly safe down to very young ages. You'll see down there that you have granules for kids 4 and under, or 6 months to 5, and then you have overlapping with that, depending on when the child can chew, you have a chew tablet that is 4 milligrams as well. In this elementary and middle school age kids from 6 to 14, you have a 5 milligram tablet, and then for adults you have 10. Those are the only ones. It's age-based. You won't see this very often, but age-based dosage forms. Again, not first line, adding on. Next page, 13, nasal cromolyn, we have talked about before. It's a mast cell stabilizer. So it keeps that mast cell from degranulating. It can be used as seasonal or persistent allergic rhinitis. It is a fairly low order drug in that it's not as good as the glucocorticoids, not as good as the antihistamines. But in some cases it can be as good as antihistamines. It's a very, very safe drug. A lot of parents will opt for this in mild symptomatic cases because it just doesn't have any side effects. The side effects are related more to the product and burning or irritation than it is to what the drug will do. So look under expected clinical effects. Nasally, it seems to work faster than we use it. Like when we use it for asthma, it takes weeks for you to see effects. But in the nose, it seems to work well before a known allergen exposure. If you can get it in 30 minutes before, let's say you go to your friend's house, they have a cat or a dog, and you know it's going to make you symptomatic, you take this, it will reduce or keep those symptoms from occurring. So it's good for people at episodic exposures to known allergens. But it can be used all the time, can be used seasonally, can be used episodically. So very versatile, but again, it's going to hit more of the lower order or less significant symptoms if you're using it by yourself, by itself. Can be added and used with anything. So they're versatile in that respect as well. At the bottom, there are a couple of pictures of nasal saline irrigation. Ocean, I like Ocean nasal spray. There's generics. You can get them very cheaply, inexpensively for $1 or $2 a bottle. Simply Saline is more of an aerosol. Some people like it as opposed to the sprays. People can use these ad lib. I like them in the winter time because they can moisturize the nose, especially in people who have irritation or have nosebleeds from time to time. Sometimes this will just help keep that nose moisturized. You can use it with any of the other topicals. Using it before help loosen up their mucus, blow their nose. Sometimes it will help. That salt in the saline part will help break up that mucus and make it easier to blow their nose. Netipots. Anybody use a Netipot? Oh, these. Last year there was about half the class. You're brave, I think. So you can do your own irrigation in using a Netipot. I gave you a website there for making up. This is the American Academy of Allergy and Asthma. They're a great group. They have a formulation if you want to make your own irrigation. If you are going to use it, use the most sterile water you can. Don't trust your tap water by itself. So using distilled water, sterilized, previously boiled. They are easily contaminated by your own bacteria in your nasal cavity. If you are in areas where water quality may be poor, then you there's an amoeba. So this amoeba, found in freshwater lakes, a lot of times people get it. Stagnant pools will have them. So in Valerie, and I put a brain there just to show you what it does. So they call it the brain eater, but really it's a necrotizing, causes a lot of bleeding from the brain, mostly the frontal lobes. So that's the warning on Netipots. Keep them clean. Questions or comments? Those of you who are Netipot fans.
I told them this yesterday, but you have to keep your mouth open or else your water boils yourself.
Yeah, I can. You can.
Yeah, well, that's what I did.
How did you?
So that question.
So I'm really curious as to why do you use them?
Oh, well, I don't anymore.
No, people in general.
I have extremely dry nose, and like I have a humidifier in my room. Like I take other, precautions, but it's never enough. So when I'm feeling excessively dry, I will use it.
I have seen it for people when they are also just so gunked up. If you can get the air cleaned out, the drugs will work a whole lot better.
Well, I guess a lot of my friends who are like performers in New York, when they're like gunked up, when they have an audition or something, they'll use it like 5 days in a row to try to clear it all out.
Yeah,
so
yeah. I can
get
see
resonance.
that. Just keep them clean. Okay, treatment of allergic rhinitis. Let's look at that. Okay, I know you've discussed this, right? Okay, if you look on page 19 and page 20, I made you 2 tables. You can do what you want with them. The first one on page 19 is a treatment of mild intermittent, and on page 20 is persistent or moderate. It kind of gives you a flow of, the first one gives you options for intermittent because there's lots of things you can choose, and then the second one is more the flow of adding. Look on the second page. I want to just point a couple of things out. This will be true when we get to asthma. Triggers are really important to identify because for a lot of people, if you can do allergen or trigger control or allergen avoidance, you can help a lot in terms of the amount of symptoms they have and also the amount of, okay, y'all are you with me? Okay, bottom of page 16. So I think Professor Brooks talked about triggers. Yes? Okay. Identify them, always ask about them. A lot of times patients will know. They'll know, they'll tell you, here's what sets me off. And in asthma, we will do a lot of allergy assessment. We may even send them to an allergist to determine, or for immunotherapy, especially if they have a really poor case, if you can't control their asthma, or if they're not responsive to therapy as we expect them to be. So triggers are really important. Teaching patients how to control them also important. Just some things under environmental control. So if patients are in damp places, If your patients are renting and their landlord isn't very good about addressing broken pipes or mold on their walls or roaches. Roaches are a big allergic component. So those kinds of things are need to be addressed. I have written letters and I have called landlords. It's like, get that cleaned up. Reducing dust collectors, controlling dust, just changing filters is a big thing, and doing that on time. Filters are pretty inexpensive. Usually you can do $1 a piece. Exposure to cats and dogs also. Smoking, huge. And with kids, remember, kids don't always have that option. So their parents may smoke, their grandparents may smoke, whoever transports them may smoke. So really important to address those. Okay. So this shows you all the different kinds of basements. Well, in here we don't have to worry about it because we don't have basements in Oklahoma very often. But kids that play in basements, they are usually damper. There are certain molds that grow in basements. I've seen kids die from certain molds that they got from being in basements. So keep that in mind if you go or live in other parts of the country. Keeping your windows open is a bad idea if you have lots of allergies. Air conditioners are great. Not everybody has them. But having at least an air conditioner, you sleep in an air-conditioned room, those help a lot with pollen control. I know it's wonderful to sleep with an open window, but if you have allergies, it's not a good thing. Okay, so medicines to treat allergic rhinitis, we have gone through those. What I want you to do is to go over to page 19. I'll just walk you through these. So you kind of have to look at our symptoms. What's the severity of the symptoms? Are they mild, moderate, severe? Are they intermittent? Are they persistent? Okay, did they give you a definition of those? What would be considered intermittent?
On and off, like it.
Not every single day.
Right. So did they talk about if it's less than 4 days a week for less than 4 weeks? Okay.
More than 3 months.
Sinusitis.
The American Academy looks, or the allergy group looks at more than 4 weeks. More than 4 days a week. I'm not going to hold you to it. I think it's helpful, but if she didn't give it to you, we'll use common sense. Okay. I'm not going to ask you for it. But we're looking at intermittent for children over 2 and older. They're pretty much the same. So this is one of those where kids and adults don't differ very much. You can use any of these pharmacologic categories. So you could use an oral antihistamine. We use a second generation. You could use an antihistamine nasal spray. You could use an intranasal glucocorticoid. They are the most effective of the whole group. Or you can use a mast cell stabilizer. So I want you to know all the classes of drugs you can use. The medications you need to know are the ones that I have bolded. Okay? They're examples out of those categories. So for the second generation, I chose cetirizine because you can dose it as low as 6 months. And it comes in a liquid, so it's easy to dose for kids. You'll notice that for the most part, all of these can be used as needed. So that's what you want with intermittent, as needed, on demand, or you can use them regularly. Any of these could be used regularly. You look at their symptoms and how much they're having. I would say go local before you have to go systemic. So if you can do a nasal spray, do a nasal spray, whether it is an antihistamine or you use a glucocorticoid. For an adult, I would almost always go to an intranasal steroid. For a kid, I might use the antihistamine just because of effects of steroids. You'll also see under the intranasal glucocorticoids, if you've got predictable exposures, those are the easiest to manage because with those, you pre-treat, treat through the exposure if it's going to be more than just, you know, a short period, a couple of hours. And then with the steroids, they recommend treating a couple of days past that. So that's their recommendation. With the mast cell stabilizer, you can use it 30 minutes before an exposure, low risk, especially if the symptoms are low grade. Started 4 to 7 days before prolonged exposure, so that would be like before a season starts. If you know flowering trees are always going to get you, you would start now. You would start the month before. If you don't watch the TV or the news, every night they give a pollen count. So you can always look, what is the most problem? Molds, trees, they'll tell you, weeds, grasses, they'll tell you. You can go online and look every day, and they'll tell you what the count is. So if you know you have certain problems, grasses in the summer, when your next door neighbor is mowing their lawn, shut your door, shut your windows, turn your air conditioner on. Okay, next page. Persistent or mild to moderate. First choice is going to be an inhaled glucocorticoid. If they're the most effective, go with them. Choose a low bioavailability if you can't. If it's a kid, I would say you must, you should. If they're an adult, you could choose a first generation if that's what would be paid for, but a lot of these are over the counter now. So it may go to choice. So either, I put Moment, it's Moment, but just cross that in out. Fluticasone. So one of the two of those. If the first choice fails, means their symptoms do not fail, they fail to respond adequately to the first, the glucocorticoid, then add one of the following. You could add an antihistamine to it, or you could change to a combination product, like the Dynesta. Or you can add a second generation oral antihistamine. If somebody did not want to take a nasal spray, you could add the oral. Depending on their symptoms, if they have nasal congestions, not responding to that steroid, and they have symptoms that will respond to an antihistamine, then try an antihistamine decongestant combination, in addition to the intranasal glucocorticoid. If they have excessive rhinorrhea, then try the ipratropium. If they have asthma and allergic rhinitis, you might try, that's the place where you would try montelukast with the medicines that they're also being used for asthma. So it would be okay to use an asthma inhaler for their asthma and an intranasal glucocorticoid. If they have allergic rhinitis and allergic conjunctivitis, then use an antihistamine eye drop, plus the intranasal glucocorticoid. Questions, Dan? In pregnant women, the first thing is allergen avoidance. Okay, so that's why I emphasize at the beginning their triggers. Try that. So we're going to try to avoid a drug if we can. Cromolyn is very safe in pregnancy. They could use a second generation inhaled glucocorticoid. Use the lowest dose effective. There it might just be PRN, on just whenever they've got symptoms that aren't being controlled by the cromolyn or avoiding a allergen. So that's the mometasone or the fluticasone. Or you can do an oral second generation antihistamine, loratadine or cetirizine. Those I put down specifically because they have data that they don't have direct data in pregnant women, but they do in animals that shows safety. So for all drugs, there is a labeling system, there is a grading system, a category system for safety in pregnancy. They'll look at, is there data in pregnant women? No. Is there data in animals that shows safety or no harm? Is there data in animals that shows minor harm? And then is there drugs that we know when women take them, like warfarin, we know that there are congenital defects, okay? So the two I've given you are two that have safety profiles. Doesn't mean the others wouldn't, but these two have more safety data behind them. That's why they're listed there specifically. You would not use an oral decongestant. They're vasoconstrictors. You'll constrict the uterine arteries. Okay? So don't use a vasoconstrictor. In breastfeeding women, because these drugs tend to go through breast milk fairly easily, is again, it's allergen avoidance. Use the nasal saline as much as you can. And then if it's persistent, you can use budesonide, which is a glucocorticoid, plus a tyrosine or loratadine. Now again, these have data behind it. Budesonide's the only one that has data with breastfeeding women that I could find. Okay, all right, yes.
On the other table, you have specific things you want us to know. On this one, is it everything?
This one, I have done the flow for you.
Okay.
Use it however you want. It's a summary. Okay, that's allergic rhinitis and the drugs. Any other questions? Okay. Sinusitis. What'd you learn about sinusitis? It's what?
Infection or inflammation of the sinuses.
Infection, inflammation of the sinuses. Okay, what's it caused by? Bacteria? All bacteria? Viral. Okay, so how do you tell the difference? Color of discharge?
Duration.
Duration? Give me an idea about duration.
Said over 10 days is higher chance of bacterial.
Right. So look down under treatment. Adults can wait 7 days until antibiotics are prescribed. So that goes along with what she's telling you. Look under the first bullet. 86% of patients not prescribed an antibiotic will be cured by 15 days, compared with 91% on antibiotics. Okay. So it tells you it's really hard for people to figure out who needs an antibiotic and who doesn't. Most people don't need an antibiotic. Okay. All right. So you're gram-positive, so it's strep mostly, pneumonia. Gram-negatives are your H. fluid, M. catarrhalis, your buddies. I mean, you've seen them before, they're here again to cause trouble. If you look under treatment, similar to otitis, we're going to see the same bugs, so we're going to see the same antibiotics again. For kids, the observation period is much shorter. The sources I had used 3 days. Did she give you a different length of time? Okay. Certain situations warrant immediate treatment. Worsening of illnesses or severe onset. Antibiotics within the last 4 weeks. Where have you seen that? Okay. So it should tell you, anytime you're seeing somebody that you suspect has an infection, you're always going to ask if you had any antibiotics in the last month. Concurrent infections, other things going on. Respiratory tree tends to go up and down, so you can have pneumonia as well, pharyngitis. Okay, first line treatment. Let's walk through this. So they divide, so for oral treatment, they divide it into standard and high dose. So standard, we use amoxicillin, clavulanic acid, or ometin for adults. You'll see the dose there. I'm not going to ask you to remember it. It's 875 twice a day. For high dose, it is, if you look down there, it's 2 grams BID. So when would you use that? So if your resistance is very high in your area, they've had recent antibiotic treatment, they're older, recent hospitalization, immune compromised. So there you've got big risk factors for resistant or superbugs. Okay. So you've seen this again, so it comes home again. It's a little bit different risk factors, but it's the same kind of concept. I need to figure out what could be working against me if I use this antibiotic, or if I choose an antibiotic, what's going to undo it or not make it successful. If they're penallergic, you've got doxycycline, which is what type of antibiotic? Tetracycline. You've got levofloxacin, which is what? Fluoroquinolone, and moxifloxacin, also a fluoroquinolone. For kids, standard dose. Now the dose here is different. It's about half of what you're used to. It's 22.5 milligrams per kilo twice a day. Or it's 45 milligrams per kilo in a day. And you're going to divide it, give it twice. High dose is what you're used to with otitis media, 45 milligrams per kilo BID. High dose. If you look under who to use it for high dose, it's the sicker kids. They got a temp. They've got purulent nasal discharge. They're less than 2 years of age, okay? High risk group, so start thinking about that as a separate group. Daycare attendees, bug factories, they live in bug soup, okay? Antibiotics in the last 30 days, here it is again. Penallergic. So the first one is for non-type 1. Again, you see the cephalosporins. You've got second and third generations there. Cefuroxime is second, the other two are third generation. For kids less than 2 with a type 1, you've got your clindamycin, you've got Zyvox and Levaquin, Cefixime, which is a third generation, or a fluoroquinolone alone. Hospitalized, I'm not going to ask you these. Know that it's IV. You're using much more potent antibiotics. You're using ones that are better against resistant organisms. So keep that in mind. Duration there, children longer, about twice as long, 10 to 14 days for kids, 5 to 7 for adults. Next page. Same thing we talked about otitis. If they're not better in 48 to 72 hours, reconsider your antibiotics. So second lines then there are listed, fluoroquinolones, tetracycline. Start thinking about getting somebody's help about what may be going on. That table is a summary table of just what I have said in terms of initial management and then what do you do if you're worse in 72 hours. You can use Tylenol or NSAIDs for pain or fever. You can use intranasal corticosteroids to help with the inflammation, help with comfort, decrease pain. Antihistamines, decongestants, not recommended in this scenario. So treatment summary, why are adults and kids managed differently? Comes down to who's looked at them, who's published the guidelines, what is the usual. So they don't, I told you they don't do a lot of studies in kids, so people publish their findings. In our hospital, we treated as case series of 20 kids, and here's what we did, and here's what happened. And they start to amass kind of a knowledge base that then people start to adopt and use. And that didn't work, then they'll publish that. So peds, very different from adults, where we're basing it on randomized control trials or something that has more robustness in terms of the outcome. Think preservation of antibiotics with kids. Go with the most narrow, there's little booklets, there's a red book for kids, the antibiotics. Know your target and try to hit it instead of using a broad base. The one at the bottom, the table at the bottom again is a summary table for you. Yes, Kristen.
If you have to change the antibiotic, do they need to wait like a day?
No.
You can take 2 at the same
You just
day?
switch. You just switch. Okay, chronic sinusitis. Did you talk about this one? Okay, what you learned about chronic sinusitis? 3+ months of symptoms considered chronic. Okay. What else? Very common. Yes, no? Did you talk about nasal polyps? Okay.
Yes.
All right. Okay, so we got three subtypes. We've got chronic sinusitis without nasal polyps, with nasal polyps, and then the fungal sinusitis. Okay. So treatment is with steroids and antibiotics. So I've given you the oral. We use oral prednisone. We use a taper that's a 10-day example. And antibiotics long, 3 to 4 weeks. Hard to get into that area. So it's an extended, they say you can extend it up to 6. So empirically, we've talked about empiric before. What does empiric mean?
Your best judgment.
Best judgment. What does that judgment entail? Location?
Bug that you think it might be.
So where in the body it is, where they get it. Okay. So we've talked about daycares, nursing homes, community versus hospital. Hospital's almost always worse because those bugs have lived in an area of antibiotics all the time. So they're usually resistant. They're usually the worse, the more bad kind. So likely pathogen there at the bottom. We're going to go after. We're going to cover strep pneumoniae. We're going to cover H. influenza and M. catarrhal. Same bugs all over again. Okay. So you can start to guess what the antibiotics are going to be. Next page, 25. So we're going to use augmentin, amoxicillin, clavulanic acid. And the main side effect due to the clavulanic acid is diarrhea. You do not have to know doses. I do want you to know the antibiotics though. So penallergic and MRSA, you could use clindamycin. Adjunct therapy is, and that's PO. Adjunct therapy would be the saline, nasal saline, irrigate, clean it out. And also intranasal glucose steroids can be used. Calm it down, get the inflammation down. So that's acute treatment. Then you have maintenance therapy. If you look underneath, the maintenance therapy are the steroids to keep inflammation down. Less likely to get infected. Inflamed areas are more compromised, and so you're more likely to become infected. If they've got an allergic rhinitis on top of it, then treat that as well. Go back to the different options that we looked at. Usually don't use pseudoephedrine or oral decongestants. They will be congested. The steroid should help. So this would be where you use the steroid on a regular basis. Next page. Nasal polyps, I always think steroids, okay, to manage them. So oral steroids can be used. Then once you've got them under control, you can move them to an intranasal glucocorticoid. You could use them at the same time. If you're using one of the low bioavailability ones, you could use that as you're letting oral steroids exert their effect, because they'll be bigger guns. That will help. Any other question, comment about that? Pretty straightforward with sinusitis. Let's talk about candidiasis or thrush. You're going to see this in kids. Or adults, you can. You'll see it in kids a lot when they're on antibiotics. If they're on steroids, you're going to see it. Adults, you'll see that in asthma, we see it a lot because we use inhalers that puts a steroid and deposits it right in the mouth. So we always recommend patients use and we'll talk about when we get to asthmas, we'll use a device that they will actually actuate the drug into a spacer device, and then they'll breathe in and out of that spacer device. So what happens when you use a inhaler, so this is the mouthpiece. It will have a canister of active drug in it. And when you press down on this, actually it goes out that way, then the drug is propelled out. It's under pressure, and so when you actuate it, then you get this kind of action. You get this cone spray out of the inhaler. Some of the particles are this size, exaggerating, some this size, some this size, okay? This size, the smaller size, is what can get down into the lumps. You get enough good updraft of air, you can get it down into the lumps. These big ones, they just fall out. And they fall out in the mouth and in the throat, and they'll deposit wherever they land, they'll set up, they'll just sit there. So what happens in the mouth is that we get thrush, because we use a steroid, it kills off some of the good bacteria or keeps them from working, and yeast is opportunistic. You give it a chance, it will flourish, okay? So that's where you get it from, using a inhaled corticosteroid. Okay, so what we're going to have to use then is an antifungal. If you look on page 27, you are responsible for the highlighted doses. I think you have a prescription that you have to create with these as well. So there are two types of antifungals. There's nystatin and then there's the azoles. Okay? All of the antifungals will impair the cell wall of the yeast. They'll insert themselves in the cell wall, disrupt it, and then the contents spill out and the yeast die. So the only one we use with kids is nystatin. It's a suspension. We put it in their mouth. If they're really little, you can paint it kind of on. Use your finger, move it in. You can use little swabs, swab it around their mouth. And the older they are, they can swish it in their mouth and spit it out. If you're a mom, you probably had to do this with your kids at some point. Very common after an antibiotic course to see this happen. So if you look under infants, those that are 30 days or older, nystatin suspension 100,000 units to each cheek. So 100,000 on one side, 100,000 on the other, 4 times a day for 7 to 14 days. It's a pain to treat. You always have to treat yeast infections longer. They just take longer to kill off than bacteria. Okay. The dropper that comes with the bottle is graduated. So it'll have a dose marker on the dropper. So you pull it up to that amount, squirt it in either side, swish it around, move it around, and if you're consistent, then over time it will go away. But you see, it's 4 times a day. It's a lot. It's a lot on a mom. For kids, we still use a nystatin suspension. They also make lozenges that dissolve, that they hold in the mouth and spit out. Chlorotrimazole is it's an azole antifungal, and it also comes as a lozenge. But I want you to know those suspension doses. Okay. You see, under adults, we can use the nystatin, but we've also got all kinds of azole products that we can use. Troches are like dissolvable tablets. It would be like,
Are those the ones that dissolve in your tongue?
not necessarily, you don't have to.
No.
They'll just dissolve in the mouth.
Okay.
There's vaginal troches, so they're like solid dosage forms that we put in a space, and they'll dissolve and stay in that space. They're usually well tolerated. They might upset the stomach, but overall they're fairly well tolerated. Big doses can cause liver problems. In these size doses, not likely, especially in kids. Now adults, if we have to do it long term, that's different. Fluconazole, I'm just going to point that out. I'm not going to hold you responsible for that, but fluconazole, very powerful oral antifungal. We're going to see it over and over again as we go through and have to treat other fungal infections. Next page. Herpes simplex. Okay, so herpes simplex virus, right? So we're going to use an antiviral. Same ones you've seen before if you look down there. Are valacyclovir, famciclovir, acyclovir. So any of those can be used. They're oral. You can also use where did I put those? The creams down there on the bottom. So you can, if the person's had a lesion before, and they usually get a prodrome, they'll get a real itchy area for a day or two before the sore appears, you can start treating then. If you do, you can usually decrease the duration of that lesion by a day or two. It will not prevent it, but it can shorten the duration of the infection. Topical anesthetics can be used to decrease pain if they're having a lot of pain with that at the very top. So like the over-the-counter, the Abreva cream, if you've ever used it, same type of thing. It's meant to apply either before or in the first day that the lesion appears. So they are only there to shorten duration. Okay. I'm going to skip page 29. Go to pharyngitis at the end. It's so common. So this is a couple of differences here. So usually the one we're worried about the most is group A strep. You look under treatment, it's penicillin. You don't see penicillin very often anymore for any infection. But here it is. So PenVK is the preferred. There is an injectable form of penicillin. That's what's right under that. Benzathine, penicillin G. It's more expensive and it hurts. It's very painful. But if you had somebody that you were worried they would not take the oral drug, because what you learn, if you don't treat adequately strep pharyngitis, what happens? Heart and what else? Kidneys. You talk about?
Yes.
Okay. All right, so it's imperative, you have to get it across to people, is that you've got to treat it, and you've got to take your antibiotic, because they will feel better in a day. Those symptoms go away very quickly. So you've got an injectable if you wanted to use it. You can use amoxicillin. It's the only time you will see it recommended as a once a day. The penallergics, if you're, again, non-type 1, you're looking at cephalosporins. Here you've got cephalexin. That's a first generation. Very good against gram-positives. And then if you've got a type 1 penicillin allergy, you can use the macrolides or clindamycin. It's the same things we've seen over and over again. The table up on page 31, you do not have to know, I'm just showing you. So you'll see for the PenVK, it's for kids, it's 250 milligrams BID, TID, 10 days. And the PenG, benzathine is once. So keep it in mind. I wanted to talk about adjunct is, you know why we don't use aspirin in kids under 21. So we recommend that kids do not take aspirin who are under the age of 21 because there's an increased risk of something called Rye syndrome. Rye syndrome is a neurologic complication due to usually a viral event, viral infection. And it can cause death. It can cause neurologic impairment. So Rye syndrome is the reason we don't use aspirin or recommend aspirin in children. That's why we use Tylenol or ibuprofen.
After the test, is it 21 months?
No,
21
years. You might see 18 as well, but in the 18 to 21 would be up to that point. Really? You all have never heard that?
I've taken aspirin before.
Isn't baby aspirin?
It doesn't matter what
Baby
aspirin
aspirin
is,
just
it's not
smaller than-
recommended.
No, I don't say baby aspirin.
Oh, maybe because it was originally, you're right, it was developed for kids. I mean, it's been around since the thirties.
That's what I thought, but they don't recommend it
Yeah,
at
it's
all.
like not for children.
Why is it called baby aspirin?
Because it was a chewable, it was a baby aspirin, it was intended for kids. Well, the Rice syndrome came about probably in the 70s or 80s.
That's funny.
They started seeing it after the flu, and kids start dying.
No.
So they recommend, do not use it. So I haven't seen any change in that recommendation.
Did they up the age? Because I remember that, but I thought it was like after 12 or something.
I've always, 18 to 21 is originally, I'll go back and look at it again, but yes.
So what would be like the mechanism of action there if it's after a viral event?
It's almost always after a viral event.
So what part does aspirin play in that?
I can't tell you the mechanism. I'll look it up, but I can't tell you off the top of my head. My brain can only hold so much.
Sympathize.
All right, questions? Yes.
So the sinusitis, how would you treat that? Because you can't access that when you're switching, so it would be oral.
I don't know if they go in and use a IV fungal side, and those are really hard to use, and they're very nephrotoxic. So, I don't know. Don't see them very often. Thank goodness. No, I'm not gonna hold you to it for us. Now, if whatever Professor Brooks did on that, she's gonna hold you to that, but I'm not gonna test you over it. I've only got 8 to 10 questions, I can't guess. That's why you got to hit the big stuff. Big stuff. Okay, all right.